Hello, everyone. On behalf of the American Heart Association, I would like to welcome you to our webinar, Practical Use of IV Iron and Potassium Binders in Heart Failure Management. I'm Natalie Navarre, and I'm the Senior Program Development Manager for Get With the Guidelines Heart Failure. Today's webinar is brought to you by the American Heart Association's Get With the Guidelines Heart Failure program. The AHA's 5 inpatient Get With the Guidelines programs, shown here on the screen, promote adherence to the latest research-driven guidelines and provide data and reporting capabilities to drive continual improvement in patient care. The QR code on the screen will allow you to request further information on our programs. Our presenters today are Dr. Robert Mentz and Dr. Stephen Greene. Dr. Mentz is an associate professor of medicine and chief of the heart failure section at Duke University. He is also co-editor-in-chief of the Journal of Cardiac Failure, the official journal of the Heart Failure Society of America. Dr. Mentz spends his clinical time at Duke University assisting with the care of patients with heart failure, cardiac transplants, and ventricular assist devices. He is a leading clinical trialist in both traditional and pragmatic studies. Dr. Greene is a heart failure cardiologist and associate professor in the Division of Cardiology and Duke Clinical Research Institute at the Duke University School of Medicine. Dr. Greene's research focuses on improving quality of care and outcomes for patients with heart failure. He has served on leadership committees and led multiple analyses from national and international heart failure registries, characterizing the quality of heart failure care. Dr. Greene is also a volunteer dedicating his time and expertise to our Get With the Guidelines Heart Failure Systems of Care Advisory Group. Thank you, Dr. Greene. And now I am happy to turn it over to Dr. Mentz to begin his portion. Thank you.
Yeah, thanks so much, Natalie. I'm looking forward to the discussion today. So over the next 20 minutes or so, I'm going to go through some real practical insights around managing iron deficiency in patients with heart failure. I'll go through the trial data, talk about how we've implemented intravenous iron at our institution, and share some of the key consensus papers and documents that help us translate data into clinical practice. And then I'll hand it over to Steve to go through some important data and insights around hyperkalemia. So just by way of outline, I'll give some of the background on the epidemiology of iron deficiency and heart failure, go through some of the earlier IV iron trials, which you may be less familiar with. I'll present some of the data around HEART-FID, the largest IV iron trial that we helped lead here at Duke, and then go through some of the more recent data from FAIR-HF2 and one of the HFPEF trials as well. Then I'll try to bring this all together for your clinical practice. I'll draw your attention to this really nice scientific statement from the Heart Failure Society of America, now published a couple years ago. It gives a really good background on the definitions that we use in iron deficiency in patients with heart failure. It goes through the epidemiology, which I'll highlight some of the key messages today, and then it synthesizes the data as we translate this into clinical practice. This is a really important slide. It talks about the definition of iron deficiency. It's been used in the majority of clinical trials in patients with heart failure and intravenous iron. And this is what's noted in the clinical guidelines. So it's a ferritin less than 100 or a ferritin of 100 to 300 with a TSAT or a transferrin saturation that's less than 20. Importantly, this is regardless of anemia status. So many of us were taught in our training to think if you see anemia, then you think about iron deficiency. A key take-home message that I'll deliver is really that when you see patients with heart failure, think about iron deficiency, check iron studies, and this is how we define iron deficiency. So again, just a reminder, it's ferritin less than 100 or up to 300 if their TSAT's less than 20. And this is an evolving space, and there's some data now that suggests that we may be able to transition more toward just focusing on TSAT, but we still await some prospective studies examining that definition. To give some context of how common this is, these are just a number of different clinical trials that have looked at the percentage of patients with heart failure that have iron deficiency by that definition I just went through. And you can see on the left is chronic or outpatient ambulatory settings. It's about 35 to upwards of 50–60% of patients. And in the acute decompensated state or in the hospital, it's upwards of 70 to 80% of patients have iron deficiency. And importantly, this is actually regardless of ejection fraction. And while much of the data I'll discuss today are looking at iron deficiency in HFrEF and intravenous iron in that population, we do have some preliminary evidence now of a potential benefit with intravenous iron in HFpEF as well. So here's some sense of why do we see iron deficiency in patients with heart failure. On the left is some of the physiology. This is from that scientific statement. So what you can see here is patients with heart failure, they tend to have less iron in their diets. They have less intake of iron. As a result of gut edema, they actually get less absorption of iron. The next step, actually, in terms of bioavailability, the iron that comes into the system, it tends to be sequestered in different stores related to inflammation. So even if the iron is being absorbed, we see that it tends to be sequestered or is not able to be used. And then many of these patients are on blood thinners or antiplatelet agents, so there can be actually increased loss of iron through blood as well. So really each step of the process is impaired, from taking in iron to absorbing it to sequestering it, and then also increased loss. And I love this older figure on the right that shows how iron deficiency goes from the mitochondria to the heart to the skeletal muscle to the individual patient and the experience that they have, and how this impacts quality of life, functional status, and clinical outcomes. So to show you some of those data about worse outcomes, on the left is one of the seminal papers that first looked at iron deficiency and showed that patients with heart failure, that having iron deficiency was an independently poor prognostic marker for worse mortality. And on the right of the screen comes to this question of anemia or low hemoglobin levels with or without iron deficiency. And to me, this is one of the foundational concepts that we actually see iron deficiency associated with worse outcomes, even in patients that don't have anemia. So next up, you say, well, my patient has iron deficiency. I realize this is really common. What about oral iron? Will oral iron help replete their stores and improve their clinical outcomes? And we have one important randomized trial, the Iron Out study conducted by the Heart Failure Network, that looked at patients with heart failure, iron deficiency, and gave oral iron, and there was no difference in some of the key endpoints that they looked at. The primary endpoint of peak VO2 or functional status measure, and all of the secondary endpoints really didn't suggest any clinical benefit. And you say, well, why is that? They're iron deficient. I'm giving them oral iron. And what we saw was that it actually, oral iron was not absorbed in these patients. It did not increase their iron levels. So on the top right, you can see when we look at ferritin in those patients that got oral iron, there was no difference from placebo. Ferritin did not go up over a 16-week period. And this is really in stark contrast on the bottom of the screen, one of the key foundational trials, FAIR-HF, that looked at an IV iron formulation, where you can see robust repletion in those iron stores going up over a 24-week period. So key message here in the foundational trial looking at oral iron and iron deficiency and heart failure, no clear benefit. And as we talk about starting new therapies in our foundational 4 and HFrEF, we also can think about deprescribing. So many patients that are on oral iron, well, we can stop these therapies. There isn't a clear benefit. They can lead to constipation, challenges with polypharmacy. So I really routinely stop oral iron. We do not have evidence of a clear benefit. So now what about IV iron? I mentioned the FAIR-HF trial briefly. This was one of the first trials. This was 450 or so patients, 24 weeks, and looked at a patient global assessment and symptom change by NYHA class. And this was with one of the IV iron formulations. And then the same formulation, ferrocarboxymaltose, was also looked at in CONFIRM. And then the EFFECT trial, you can see a couple hundred patients looked at functional endpoints, 6-minute walk distance, and peak VO2 or maximal oxygen consumption, and really showed consistent benefits around functional status with IV iron, biomarkers like natriuretic peptide, and patient global assessment. But importantly, these trials really weren't designed to assess clinical outcomes. But to give you some sense of the magnitude of benefit, here's from the CONFIRM-HF trial, 6-minute walk distance. You can see it out to a year, about a 30+ meter benefit. So this is on the order of magnitude of what you see with cardiac resynchronization therapy or biventricular pacing, really a large benefit around functional status benefit. And then on the bottom, you can see some exploratory data suggesting that there might be an improvement in clinical outcomes with IV iron, but we needed larger follow-up studies to help better explore these hypothesis-generating data. So with that, we had 2 subsequent trials of intravenous iron in HFrEF with iron deficiency. The first of those on the left of the screen was the AFFIRM-AHF trial, looking at one IV iron formulation, ferric carboxymaltose, over 1,000 patients. with a primary endpoint of cardiovascular death and total heart failure hospitalizations or recurrent events, and it suggested about a 20% reduction in clinical events, but this did not reach statistical significance. Importantly, this trial was conducted during the COVID pandemic, and they pre-specified an analysis and did demonstrate that there was a clinically significant reduction in clinical events if you accounted for the COVID considerations. So this was with one formulation, and then the Ironman trial was a trial conducted in Europe. It was with IV ferric durisomaltose. It had the same primary endpoint, showed a relatively similar magnitude of risk reduction, about 18%. And again, this was not statistically significant. It was also impacted by the COVID pandemic and showed pretty consistent results to what we saw with AFFIRM-AHF. So in summary, there was a nominal reduction really driven by a reduction in heart failure hospitalizations with two different IV iron formulations, but none of them individually reaching, or neither of them individually reaching statistical significance. So you say, well, what if we put all the data together with these IV iron formulations in HFrEF? And after Ironman came out, you can see here a really nice Bayesian meta-analysis. So it's taking the totality of evidence, which suggests about a 27% reduction in clinical events of CV death and heart failure hospitalization. But on the bottom, you can see that there is still some level of uncertainty. So further data were needed to help best support guideline recommendations and clinical implementation. So with that background, what did the guidelines say at the time? So these are the ACC/AHA HFSA 22 guidelines and then ESC in 23. So the US-based guidelines gave a 2A recommendation in HFrEF with iron deficiency, again, regardless of anemia status, to use IV iron to improve functional status and quality of life. And on the bottom, you can see the ESC guidelines, which actually came out the day before we presented the HEART-FID trial. They gave a class 1 recommendation for IV iron for heart failure symptoms and quality of life. So the highest class recommendation based on those number of clinical trials that I presented. And a class 2A recommendation for heart failure hospitalization. So importantly, the ACC/AHA HFSA guidelines do give a class 1 recommendation in patients that are who are diagnosed with heart failure, that when we're doing that laboratory assessment, that iron studies should be performed. So this is really helpful to think that in our patients with heart failure, we have a class 1 recommendation to check iron indices. So I mentioned the HEART-FID trial. This was a double-blind placebo-controlled event-driven trial, HFrEF, with that iron deficiency definition, and looked at a primary endpoint that was a hierarchical composite, meaning we first looked at mortality between the two groups, then we looked at heart failure hospitalization, and then we looked at change in 6-minute walk distance, and importantly also had a more traditional endpoint of time to first event of CV death or heart failure hospitalization. So this is the largest of the trials, nearly 3 times the size of the earlier studies. And what we found was a numerical reduction in mortality, hospitalizations, and a clinical improvement around 6-minute walk distance, but more modest treatment effects than we saw in the earlier trials. And this did not reach our pre-specified level of statistical significance. Often we'll see the p-value cut point of 0.05. Given that this was designed as one pivotal trial, we actually had to target a p-value less than 0.01. So this did not reach statistical significance, and using this win ratio, we saw a win ratio of 1.10, or 10% more wins with IV iron is compared with placebo. But again, not reaching statistical significance with 99% confidence intervals noted here. So you say, well, why was this? And some important analyses to better understand this. We found that our baseline TSAT, or transferrin saturation, actually tended to be higher in this group. So the earlier studies, the TSAT was around 15%. Ours was in the 20s. So I think despite using the same criteria, we tended to have a population that may not have represented what we're more consistently thinking about as iron deficient now. We were also impacted by COVID, and the majority of events actually accrued during COVID. And we know heart failure hospitalizations were really impacted during that period. But we did see a subset of patients that had more substantial benefits around functional status, because overall we saw just more modest treatment benefit for functional status in this trial. So as I put all the data together, I think the earlier studies show a functional status and symptom benefit. We now have multiple clinical trials suggesting a clinically significant benefit, but none of them actually reaching statistical significance in and of themselves. So after we presented HEART-FID, we followed that with a meta-analysis because we thought that this was important to summarize the data. And you can see here, when we look at all of the different IV iron trials, this does reach 24% reduction in the primary endpoint. And then next up, we did see that it seemed that TSAT less than 20% might be the group with the larger treatment benefit. And we do have an ongoing study now, which I'll note in just a second, called ICONIC, which is just looking at a TSAT less than 20 to get into the trial. So you say, well, we've looked at a number of clinical trials now. What other recent data do we have? There was one other recent trial, FAIR-HF2, which looked at a slightly different iron repletion strategy. This looked at giving IV iron in follow-up, including in those patients that had higher ferritin levels to see if not just a repletion, but a supplementation approach could lead to improved outcomes. This trial had some funding challenges. It took longer to complete, and I'll show on the next slide. They actually changed the endpoint in the trial and had three different components of this endpoint, including that time to first event of CV death and heart failure hospitalizations in all patients. You can see a pretty similar magnitude of benefit, about a 20% reduction in clinical events. And then they looked on the right was that recurrent event, also pretty similar to the earlier trials. And then they focused just on that TSAT less than 20 group, as you can see on the bottom of the screen. All the point estimates are pretty similar, but not reaching statistical significance when you look at all the components of this, which were required given the three specific analyses. And then finally, we wanted to make sure we synthesized the whole message. So here was a pre-specified analysis now looking at all the data to date in HFrEF. And we see a 19% reduction in recurrent heart failure hospitalizations and CV death during all the follow-up. And if you look just at the 12-month period, you can see that's a 28% reduction. So it does seem that the treatment benefit is largest in that early period after giving IV iron up to a year. So with this, we felt that it was important to hopefully definitively answer this question for the clinical community. We have an ongoing study now called ICONIC, which is looking at ferric diisomaltose compared to usual care or not giving iron. And it's just looking at a TSAT less than 20. So we await those data, which will hopefully give us the final trial to demonstrate a clinical benefit. It often comes up, individuals will say, well, what about heart failure with preserved ejection fraction? We have pretty limited data there. Here's one randomized trial that struggled with the funding for this, and it took a long time to recruit. It was slated to be a larger clinical trial, but ultimately just recruited 39 patients. It was EF 45% or greater. But on the bottom left, you can see they did show a clinically meaningful and statistically significant benefit around 6-minute walk distance, almost 50 meters at 24 weeks. And one of our star fellows, Mark, helped lead this nice editorial on the right to help contextualize these magnitude of benefits as we think about other therapies for HFpEF. So to summarize this, and then I'll try to pull all the clinical elements together, as I look at the data, the early clinical trials with IV iron show benefits around quality of life and exercise capacity. The ESC guidelines give it a class 1 recommendation there. We have multiple outcome studies that have looked at IV iron, and they have suggested potential benefits, none of them individually reaching statistical significance. We summarize HEART-FID by demonstrating and summarizing. I do think that IV iron is safe and that it does have clinical benefits for patients, even if individually these trials didn't meet statistical significance. And there may be some patients that have a larger response or benefit compared to other individuals. And in particular, I think it's that TSAT less than 20%. There are ongoing investigations to look at that iron deficiency definition, understanding the dosing and timing. There were some initial considerations of, is there an interaction with SGLT2 inhibitors? Do we need to worry about that? Because we do see more an increase in hemoglobin levels with SGLT2 inhibitors. To date, none of the analyses in our different data sets have suggested any differential concern in patients on an SGLT2 inhibitor. And then again, I do think we need larger studies in patients with HFpEF. And there have been a couple recent submissions by different NIH funding mechanisms around that. So hopefully we'll get some data in that space down the line. So to now try to bring this all together, here's a really nice paper that was in JACC Heart Failure in 2024 that looked at the different clinical evidence, tried to understand how we could incorporate this into real world practice, thinking about implementation toolkits, and then which patients is it appropriate to consider. Some of the common things that'll come up are historically, many of us were taught if an individual patient has an infection, is giving them IV iron going to increase infection risk? Actually, most of the data do not support any infectious concerns. And actually, there are data from Ironman that there actually may be a reduction in infectious considerations, including maybe even COVID, in patients getting IV iron. That being said, we don't have any specific randomized trials dedicated to that. So my approach is typically to let the treatment of the infection occur. And then, for instance, if they're in the hospital, you can give IV iron before they're discharged. To give you one other example, here's our strategy at our institution, the different steps we go through. So we see a patient either in the in-hospital or outpatient setting with heart failure. We check iron indices. We understand whether or not they are anemic as well. Our pharmacists help support the IV iron infusion at our institution. In the in-hospital setting, we can do this pretty easily on the floor. But in the outpatient setting, we often have these patients go to an infusion clinic just for ease of administration. There are some old carryovers with older formulations. There was worry of anaphylaxis or other reactions. With the newer formulations, that's very, very uncommon, but that has historically been a barrier. So we do have appropriate safety measures around that. And really, I think this underscores the value of multidisciplinary teams engaging with our nurse practitioners, physician assistants to identify these patients, give these therapies, and our pharmacist support to help implement and then follow up. So actually, at a 3 to 6 months cadence, understanding what do their iron indices look like, and do they need additional IV iron infusions. In the trial data at a 6 month cadence, about 20% of patients may need additional IV iron infusions. So with that, I will thank you for your attention. For those that haven't been to Hogwarts down at Universal, I got to give it two thumbs up. You get your butterbeer. This was us actually 2 falls ago now. But thanks so much. I'm looking forward to the discussion. I'll hand it over to Steve.
Thanks, Rob. So awesome talk. And now we're going to transition from IV iron to thinking about hyperkalemia in patients with heart failure. So we all know when we're thinking about heart failure with reduced ejection fraction, we have our quadruple medical therapies. These are the things that are strongly recommended in the clinical guidelines for improving our patient outcomes. But it's important to recognize that these therapies don't just work. They work really, really well, and they're really, really important in the sense that they improve the endpoint of all endpoints, all-cause mortality. And these are some of the older trials. You go down memory lane here. Consensus, one of the landmark trials with ACE inhibitors, RALS with the landmark clinical trial for spironolactone and HFrEF. Again, major reductions in all-cause death, not to mention the benefits on heart failure hospitalization prevention. And then, of course, in the RAS inhibitor class, we also talk about ARNI, which actually had even incremental all-cause mortality reduction compared to ACE inhibitors. So again, these therapies don't just work, they work really, really well with huge magnitude of benefit. And now we're talking about RAS inhibitors in heart failure with mildly reduced or preserved ejection fraction after struggling for so long to have definitively positive clinical trials for this patient population. We now have, I would argue, the second pillar in HFpEF medical therapy, and that is nonsteroidal MRA finerenone. The Fine Arts trial, presented now a couple of years ago, again, was definitively positive, finerenone versus placebo in MREF and HFpEF, significantly reduced the risk of CV death or total worsening heart failure events. So again, a second pillar that's really important for HFpEF medical therapy. But those are the good when it comes to RAS inhibitors and MRA, when it comes to efficacy for HFrEF and HFpEF. But now what is the downside? Well, the downside that we all frequently think about, worry about, is hyperkalemia. hyperkalemia. And this, unfortunately, is the side effect that is consistently seen in our RAS inhibitor trials, but specifically also the MRA trials in particular. And these are, again, the landmark trials in HFrEF and HFPEF. You see there's a 2 to 3 to even 4-fold higher risk of hyperkalemia with MRA compared to placebo. So yes, they're really, really important, but this hyperkalemia risk is real. And those are the data for hyperkalemia in the clinical trial cohort. But what about real-world clinical practice? Well, our registry data from different registries across the world also corroborate that hyperkalemia is a semi to very frequent event for patients that get RAS inhibitors and MRA. And these are data from the Swedish heart failure registry, which actually just looked at a very simple analysis. Patients hospitalized for heart failure, they're on all sorts of different medical therapies, and we just follow them for 1 year post-discharge. You see that for over 1 year, about 1 in 4 had at least mild hyperkalemia, and about 1 in 10 had moderate or severe hyperkalemia with a potassium of 5.5 or greater. So again, most patients won't develop hyperkalemia, but a lot will. So we definitely need to be attuned to this. This will come up in our clinical practice as we use our RAS inhibitors and MRA. And the other unfortunate thing we know from the real world data is that once hyperkalemia happens one time, it tends to happen again and again and again. It's very rarely a one-off type of event. And these are data from Denmark that kind of show that illustrative example here. Looked at over 30,000 patients hospitalized for heart failure, followed them over a mean follow-up of just over 2 years. About 4 in 10 developed hyperkalemia at least one time. But once you developed hyperkalemia once, again, the proportion that developed the second, the third kept going up and up, and the time period between the hyperkalemia episodes continued to shorten. So the tempo with which hyperkalemia repeatedly developed got quicker and quicker and quicker. So again, hyperkalemia will come up as we're treating our heart failure patients. And we know that our therapies, that RAS inhibitors, MRA, yes, we need to use them. We need to use them aggressively, but this is potentially one of the prices to pay when we use those therapies appropriately. So we need to be prepared. What are we going to do when hyperkalemia develops? And this is kind of like the clinical conundrum on this slide that I think a lot of us think about in practice when hyperkalemia does develop. And these are the potential strategies that you could consider. I mean, on one hand, we talk about, well, increasing loop diuretics for the sole reason of just keeping the potassium under control. There, of course, is dietary things you can think about. There's also the unfortunate thing that sometimes we do is we just discontinue or de-escalate our RASI and MRA therapies, or we consider things like asking for help, like consulting a nephrologist. But again, we need to be prepared practically what we're going to do in clinical practice when we see hyperkalemia. And I think we also need to be humble with a lot of the things that historically we've recommended, don't really work very well or, really have a lot of efficacy for treating this issue. I mean, we talk about low potassium diet sometimes, but again, very difficult to adhere to. I would argue any dietary recommendation we give heart failure patients is very, very hard for them to adhere to. And I think kind of so-so efficacy at best. Loop diuretics, yes, we use them for the symptomatic management of congestion, but just to use loop diuretics for the sole purpose of keeping potassium in check, gosh, that really makes me nervous when we talk about loop diuretics being associated with worse outcomes, upregulating the RAS inhibitor, RAS system, putting extra stress on the kidney, gout flares, all that. So I really don't think of that as an optimal plan. Discontinuing RASI therapy, I mean, sure, that's one way to fix the hyperkalemia, but then you're really just withdrawing those life-saving therapies that our heart failure patients really need. So that seems like certainly a suboptimal strategy. And there's also things like sodium polystyrene sulfonate, like otherwise known as Kxalate, which, yes, we can use in a pinch, but there's really no long-term efficacy or safety data on this. It tastes miserable for patients, and there's really this thought of safety concerns. If you give repeated dosing, the concern is you might have intestinal necrosis actually happen, so that's obviously awful. So again, none of these kind of conventional strategies really get us excited for being able to manage hyperkalemia risk well at all. So let's talk now practically. What are, I would argue, much more data-driven and efficacious ways to handle hyperkalemia in our heart failure patient population? This is kind of the menu of options that I'm going to be talking about over the next few slides. So the first thing to highlight is just use some of our friends in quad therapy. So SGLT2 inhibitors and ARNI, these are therapies that we already should be using for our eligible heart failure patients to improve their hard clinical outcomes, improve quality of life, and the like. But some may not recognize that there's other silver linings of using these therapies. SGLT2 inhibitors decrease the risk of hyperkalemia. This has been seen in multiple studies, and I'll show some data in a second. ARNI decreases risk of hyperkalemia with MRA compared with an ACE inhibitor. So again, we already should be using these therapies, and just another reason to use them is that you might also mitigate risk of hyperkalemia. But the second option that I put on the menu here are the novel potassium binders, and we're going to spend some time going through some of those data. Here specifically, we're not talking about things like Kxalate, but we're talking about Patiromer and sodium zirconium cyclosilicate. These therapies, novel potassium binders, can be used to treat active hyperkalemia when and if it should arise. But also we have data on them being enablers, being able to get them on board to enable the aggressive up titration and use of RASI and MRA. So now we're going to again go through each of these therapies in more detail. So the first, our friends, the SGLT2 inhibitor class. I already mentioned class 1 recommended in HFrEF. In the United States guideline, I think it's eventually going to be a class 1 for HFpEF as well. But again, definitively shown to reduce CV death and heart failure hospitalization. You should use these therapies in medically eligible patients across the spectrum of ejection fraction. But on top of those benefits on heart outcomes, again, a decreased risk of hyperkalemia. And this has been seen in multiple of the heart failure trials over time. On the left-hand side, these are data pooled from Emperor Reduced and Emperor Preserved. These are the heart failure trials with empagliflozin. Putting those together compared to placebo, you see an 18% relative risk reduction in hyperkalemia events or the need for potassium binders. And this benefit on hyperkalemia prevention might even be accentuated among those that are on MRA. Now, again, the people that are on MRA, these are the folks that we worry about hyperkalemia the most. These are the patients that we definitely need the most help with managing hyperkalemia risk. And here, the SGLT2 inhibitors really seem to shine. In the HFrEF trials in DAPA-HF, among those that are on MRA, dapagliflozin cut the risk of downstream hyperkalemia in half. And likewise, Emperor Reduced, again, you see about a 36% relative risk reduction for moderate or severe hyperkalemia. So again, it's not just been a one-off in these clinical trials. We've seen this kind of interesting signal on hyperkalemia prevention come time after time in the SGLT2 inhibitor trials. But it's not just about preventing, serum potassium elevation and preventing a lab abnormality. This benefit on preventing hyperkalemia might actually lead to less MRA discontinuation. Now, again, we talk about our pillars of therapy. SGLT2 and ARNI are pillars in their own right. But the pillar that needs the most help, I would argue, is MRA, that has the persistently greatest underuse in clinical practice, despite being an inexpensive generic medicine. It needs all the help it can get. And fortunately, we have its friends, the SGLT2 inhibitor and the ARNI, that based on the clinical trial data seem to help with MRA tolerability, and they decrease the risk of MRA discontinuation over time. On the left-hand side, you see data from Emperor Reduced, which again shows that empagliflozin compared to placebo, among people who are on MRA at baseline, if you got an SGLT2 inhibitor, you had a 22% lower likelihood of discontinuing your MRA during follow-up. Likewise, in Paradigm HF, when you compare ARNI versus the ACE inhibitor enalapril, ARNI significantly reduced the risk of MRA discontinuation over time. So we talk about how we need to be rapid in our initiation of SGLT2 inhibitors, rapid in our initiation of ARNI. And these data show that, when you delay the initiation of an SGLT2 inhibitor or you delay that switch from an ACE inhibitor to an ARNI, you are essentially needlessly exposing your patient to excess risk of hyperkalemia and excess risk of MRA discontinuation. Not needless to mention the excess risk of death and hospitalization for heart failure that, again, we also importantly emphasize. So those are the data for, again, the GDMTs. Again, the silver lining, another reason to use SGLT2 inhibitors and ARNI is that they can actually help out their friend MRA and decrease risk of hyperkalemia. But what about when hyperkalemia still develops? Because there, of course, still will be a fair amount of breakthrough hyperkalemia, even despite our best efforts with GDMT, with SGLT2 inhibitors, and ARNI. And that's where the novel potassium binders come in. Here specifically, we're talking about two agents. One is called Patiromer. The other is called sodium zirconium cyclosilicate, or SZC for short. So first, we'll talk about the Patiromer data. And this is just like an overview of some of the clinical characteristics of what Patiromer is all about. So again, both of these agents are powder. So patients mix them with water and they drink them. And they can be used up to 3 times a day. But specifically Patiromer first. So the way this works is that it binds in the gut and it has an exchange with calcium. It exchanges potassium for calcium to lower the serum potassium levels. Onset of action is about 4 to 7 hours after the first dose. So again, with both these agents, they're not approved for emergency hyperkalemia. So, someone that has, like sine waves on their EKG and all sorts of EKG changes, those we still think about, your albuterol, your insulin, your bicarb, all those kind of things. But these will work over the spectrum of hours, not the minutes that you might need in an emergency situation. But needless to say, 4 to 7 hours, it kicks in after the first dose. We have efficacy data for that it can be maintained over the long term with reasonable safety. And with this therapy and SZC, you generally want to space it out from administration of the other oral meds just to decrease any chance that it impacts the absorption of the other important medicines. So, well, what are the clinical trial in heart failure for the use of Patiromer? So the landmark study is the DIAMOND trial. And the DIAMOND trial was a randomized controlled clinical trial. It took patients with HFrEF that were either hyperkalemic at baseline on RASI or normokalemic and not on RASI, but they were not on RASI because they couldn't tolerate it in the past. They couldn't be on RASI because of prior hyperkalemia. So it mixed those two patient populations together. Again, either hyperkalemic on RASI or not on RASI, but at high risk of hyperkalemia. And the clinical trial design here is a little tricky, and I'll try to explain it, but it's a consistent theme for all the novel potassium binder trials. So they did what's called an open label run-in. And the way this works is you take patients in this patient population, and then what they did was they initiated open label Patiromer up to 3 times a day as needed, and they ramped up the RASI and MRA. They actually targeted greater than 50% of the target dose of the RASI inhibitor and a 50 milligram target dose of MRA. So they tried to use, again, just ramp up the RASI therapy using up to 3 times a day Patiromer as needed. And then if patients were able to achieve optimal RASI therapy with Patiromer, they then were randomized. And then they were randomized to either continue Patiromer with their high-dose RASI and MRA, or take Patiromer away, continue the RASI MRA therapy, and see what happens in terms of downstream risk of hyperkalemia. So the first thing to highlight is the run-in data. So in this patient population that was either hyperkalemic on RASI or not on RASI because of prior hyperkalemia, during the run-in phase, they were able to get patients on good RASI MRA therapy and be normokalemic 85% of the time when you used Patiromer. So again, kind of gives us confidence that, hey, if we really do use Patiromer aggressively, you could really ramp up the doses of MRA for a lot of our patients. But then we'll talk about now the randomized data. What happened when you withdrew Patiromer from these patients that were on the high doses of RASI and MRA? So these are the results from the DIAMOND trial, and these are one of the key endpoints that I'll mention here, and that is the risk of downstream hyperkalemia events. Compared to withdrawal of Patiromer, Staying on Patiromer decreased the risk of moderate or severe hyperkalemia by about 37%. So again, as you would expect, a potassium binder decreased the risk of hyperkalemia, and it decreased it by a sizable amount. But it's not just about, again, serum potassium values. It's also about how are we going to best keep our patients on high doses of MRA. And Diamond also showed that compared to withdrawal of Patiromer, continuing Patiromer better helped patients maintain those high doses of MRA. About a 38% lower likelihood of needing to down titrate or discontinue MRA if you stayed on Patiromer. So again, it seemed to essentially protect against MRA discontinuation or de-escalation. Well, what about safety? Well, just to be brief here, Patiromer overall was safe and well tolerated. When you look at the total number of adverse events, numerically fewer compared to placebo. There was, again, a comparable number of patients with placebo versus Patiromer in terms of the withdrawals of from the study or discontinuation. And again, really GI side effects were roughly similar between the two, placebo and Patiromer. A little bit more hypokalemia, as you would expect potentially with Patiromer, but again, certainly overall very safe and well-tolerated profile. So that's the first of the novel potassium binders. So now let's talk about the second. And again, the name is a mouthful, but we call it SZC for short. So Patiromer, it was, as you might remember, it was an exchange with calcium in the gut. So here we're different exchange. We're exchanging potassium here for sodium and hydrogen in the gut. So again, a little different. Onset of action. So this tends to work a little quicker than Patiromer in the clinical data. As early as 1 hour after the first dose, will you start to see the effects on serum potassium, but again, still not recommended for true emergency issues with hyperkalemia. Like Patiromer, we also have efficacy and safety data over the long term for serial delivery of this agent. And then the other thing in terms of safety here, and we're going to talk about this a little later. So yes, of course, hypokalemia can happen when you're using a therapy for hyperkalemia. Yes, you can sometimes overdo it and get hypokalemia. But the thing we have to also remember here with SCC is some of the data for edema, especially with the higher the dose. This might be potentially related to the sodium load that comes with the exchange when it comes to potassium and sodium exchange with this agent. But again, need to watch out for edema potentially with this agent. So let's talk about now the clinical trial for SZC in heart failure. So there was the Diamond trial with Patiromer and HFrEF. So here we have the REALIZE-K trial with SZC in HFrEF. So overall, fairly similar design. REALIZE-K was smaller than Diamond. Here is about 200 or so randomized patients. The Diamond trial was about 880 randomized patients, but overall similar concept. It took patients with heart failure with reduced ejection fraction who were on RASI therapy, but on suboptimal GDMT in the sense that they weren't on good doses of MRA. And it took patients who were either hyperkalemic at baseline or normokalemic at baseline, but at high risk of hyperkalemia, took these patients and did, again, that open label run-in, where, again, it aggressively tried to escalate and up-titrate the doses of MRA therapy with a target dose up to 50 milligrams daily in patients. And it tried to use SZC as needed to maintain normokalemia. And then in the patients who got through the run-in with normokalemia on high doses of spironolactone, it then did a randomized withdrawal clinical trial where, again, some people, half the patients maintained SCC to hopefully keep the therapy where it's at in terms of MRA and give potassium protection, and the other half of patients essentially got the rug taken out from them, essentially taken away the hyperkalemia protection, and kind of see what happens in terms of their downstream hyperkalemia risk. So this was the primary endpoint in the REALIZE-K trial. So it was the ability to maintain normokalemia on high doses of spironolactone and without the need for rescue therapy. Rescue therapy really being, breaking the blind and using open label potassium binders to get the patient out of trouble. That was the primary endpoint. Achieving that was defined as the primary endpoint's success. So when you look at the two randomized arms, SCC really dominated for this primary endpoint, more than fourfold higher chance of meeting this endpoint of defined as, again, an optimal treatment response with SCC versus taking away SZC from our patients. And these are the some of the confirmatory secondary endpoints. So again, the primary endpoint in the trial was met, but now a lot of us want to focus on some of the key secondary endpoints. So again, the ones that I'll highlight here, kind of like we saw in the Diamond trial, SCC decreased the risk of hyperkalemia, as you might expect. It also decreased the risk of MRA discontinuation. Importantly, the trial was not powered for hard clinical outcomes, was not powered for changes in quality of life and whatnot, and it did not show any effects on quality of life. It did not show any type of improvement in hard clinical outcomes. But again, it did show the primary endpoint being optimal treatment response in the sense of being able to stay normokalemic on high doses of MRA, that MRA enablement. So now let's look at the safety data from REALIZE-K. And again, it was a modest-sized clinical trial, about 100 patients in each group. When you look at totality, overall safe and well tolerated in the sense that the number of adverse events and serious adverse events were really no different with SCC versus placebo. However, the one thing I do want to highlight is the peripheral edema data and the cardiac failure, essentially the heart failure exacerbation data. There were numerically higher risk with the SCC group than placebo. Again, this has also been seen in some of the kidney failure data with this agent in terms of, and it might be related to that salt load and whatnot. But again, just something to keep in mind when you're using SCC is that there are some data suggest it might worsen edema and potentially worsen some congestion parameters. So to sum it all up, when we're talking about how are we going to manage hyperkalemia in 2026 for our patients with heart failure. So it's important to recognize that the risk of hyperkalemia, both the real true risk of hyperkalemia, but also the perceived risk of hyperkalemia, that fear of hyperkalemia, I will argue this is a frequent barrier to initiation and up-titration of RASI and MRA therapy for our patients in clinical practice. But the good news is that with contemporary tools, hyperkalemia can be safely prevented and managed without sacrificing GDMT. I think there's this false dichotomy that you can either be really aggressive with GDMT or maintain normal potassium, but you can't do both. I will argue if we're using the tools in our toolkit today, SGLT2 inhibitors, prioritization of ARNI instead of an ACE inhibitor, and then novel potassium binders as needed, you can achieve both. You can be aggressive with GDMT, and if hyperkalemia arises, you can manage it without having to discontinue or de-escalate GDMT. And when it comes with the novel potassium binders, I think one could argue, should I do a proactive approach where patients that are at risk, I give kind of like, upfront prophylactic potassium binder as I'm ramping up the RASI and MRA, or you want to do more of a reactive approach. You just up-titrate the GDMT, and if it happens, it happens, and you start the potassium binders as needed. I think you could argue based on the clinical trial data, both could be reasonable, but either way, I think the simple fact that we have novel potassium binders available, it should give us confidence that we can be really aggressive with our RASI and MRA. And if we get into trouble with hyperkalemia, we have really effective tools for managing it. And this also includes re-challenging patients with quote unquote prior intolerance to RASI and MRA. There's so many times that I see, listed in the allergy section of the EHR, someone, can't take an MRA because of, hyperkalemia, and it's documented years ago. Again, who knows what the clinical circumstances were that at that time a few years ago. I think we need to have a very low threshold for really being aggressive in re-challenging patients. Again, knowing that if we get into trouble, we have the novel potassium binders to potentially bail us out from any hyperkalemia issues. So with that, I think we have maybe a few minutes for questions and whatnot. But again, really thank everyone for all the attention.
Thank you both so much for excellent presentations. Steve, this is really to your, or sorry, Dr. Greene, really to your point at the end about GDMT. A question is hyperkalemia no longer a contraindication for ARNI, or how can we communicate to providers how ARNI and SGLT2 can, quote, help with hyperkalemia?
So hyperkalemia is still a contraindication to RASI and MRA. So you don't want to be initiating those therapies when potassiums are like, 5.6, for example. But the point is here is that we now have tools to get that potassium lower. And then when we achieve normal kalemia, I would argue now's the time to be aggressive with trying those therapies. So yes, we're not trying to start those therapies when we're actively hyperkalemic, but get the potassium under control with a potassium binder potentially. And then we have now the luxury of being really aggressive with those therapies. And again, potassium binders aren't going to work all the time, but they work the vast majority of the time. And that's my own anecdotal experience as well, too. There's very few patients that I cannot, in my anecdotal clinical practice, get their potassium under control, where potassium is the sole reason why I can't get them on RASI or MRA, assuming they have a potassium binder that's available to them.
Yeah, Steve, I mean, that was just a great talk. And I think you underscored some of the really important considerations, right? Where you're seeing a new patient in clinic and they say, Doc, they stopped. I used to be on this spiral. They stopped it years ago for hyperkalemia. Like, so what do you actually do in clinic? So say like you scroll through their record and 2 years ago they had a potassium of 5.2. I mean, help us kind of contextualize this a little bit. What level of potassium are you getting worried about? I think the struggle has often been like a potassium of 5.1 shows up in red in their electronic health record with stars and everybody's freaking out. Help us think through this new patient you're seeing in clinic, this potassium that was a little bit elevated. How do you talk through this with them and start these therapies and how do you actually start a potassium binder if that is needed?
Yeah, no, these are all great questions, Rob. So I think the first thing is, again, you don't want to initiate RASI and MRA when people are actively hyperkalemic. So the first thing is, if a patient is actively hyperkalemic, get their potassium down. But I think, the more common situation is that situation you mentioned. Patients normokalemic today, but they have an allergy in their chart listed as like, oh, well, they were on MRA before and it caused hyperkalemia, and you see that potassium of 5.5, a couple of years ago or whatnot. My clinical practice is, first of all, were they on an SGLT2 inhibitor at the time that they had the hyperkalemic event a couple of years ago? In real world clinical practice, usually not. We know SGLT2 inhibitors are floridly still underused. Were they on ARNI instead of ACE inhibitor? Probably not, based on the real world data. So the first thing, again, is you want to be using SGLT2 inhibitors. You want to switch them to ARNI instead of ACE inhibitor. And then my own practice is just, I got to see with my own eyes for the most part. I want to re-challenge myself with the best GDMT on board and see if that in and of itself can prevent any downstream risk of hyperkalemia. But again, the guidelines tell us when we're starting these therapies, particularly MRA, we need to be vigilant about checking the potassium, soon thereafter. So again, I'm going to have it in my back pocket, the hope that if they do develop hyperkalemia, that I'm going to be able to get a potassium binder for them. Hopefully it's going to be affordable and accessible for the patient. But that's kind of my strategy. I don't usually do in my clinical practice more of the prophylactic approach. I'm not saying it's not reasonable. You could say, oh, I'm just going to be extra safe and, try to use a potassium binder up front as I up titrate the RASI. In my patient population, I'm just going to try the RASI and MRA again, and I'll use the potassium binder more on a reactive basis if I run into trouble. In terms of starting them, practically speaking, it's not complicated. I mean, the one thing that I think is convenient about this therapy is everyone knows what it is because it's the one powder that I'm prescribing. Whereas all the pills get mixed up. Sometimes you're like, am I taking that one? The patients are confused. They all know if they're taking the powder or not taking the powder. And again, you can use it up to 3 times a day. The SZC in the short term up to 3 times a day. But most of my patients who require it for the long-term use, for the enablement, most of them only require it a few times per week. I am able to usually down titrate it where they don't necessarily need it every day. I don't think any of my patients actively take it multiple times a day, although with Patiromer you could do that potentially if needed. I think that the big take home point though is that again, if we have all the scientific tools at our disposal in 2026, hyperkalemia really should not be a barrier to GDMT. These therapies, these strategies work really well. So again, we shouldn't be fearful of it, assuming we can access all the therapies in the toolkit here. Rob, I'm going to ask you a question, Rob, because this is something that comes up all the time. Are all IV irons created equal? A lot of different hospitals, have different formularies with, certain IV irons are available and certain aren't. And, the clinical studies, as you highlighted, are talking about ferric carboxymaltose and there's diisomaltose. Help us walk through what you think and what the guidelines say in terms of this. Should we extrapolate it to a class effect, or should we try to be really, really particular with our, quote unquote, evidence-based IV irons?
Yeah, it's a really great question and so practical, right? Ultimately, the IV iron you're able to use is typically based on formulary. And most of those formularies, uniquely in the IV iron space, is actually not evidence-based. So as you noted, all of the randomized trial data in heart failure are with ferric carboxymaltose and ferric diisomaltose. Many institutions do not have those on formulary. I won't get too political about some of our experience with formulary stuff at our institution. So ultimately, I think this is where the science kind of meets the art of medicine. And you may not have one of those on formulary, so we extrapolate those data and you may use a different IV iron formulation. It does mean that dosing can be more challenging. So for instance, with some of the IV iron approaches, people will calculate like an iron deficit and then give a specific formulation. And some of them takes like 3, 5, 6 days if you're going to dose it. Whereas some of these quote unquote like higher dose formulations like FCM and ferric diisomaltose, it's basically 1 or 2 doses and you can give this. So there are some of those considerations. I'm of the mindset where we without data that there's clearly a class effect, if I were either wearing clinician hat or a patient hat, I would want to use the therapy where that we have the data. There were some really thoughtful questions that came in the chat box about hypophosphatemia. That is one thing we see with ferric carboxymaltose that we don't see with the other formulations. For those basic science people on the call, there's a lot of science that's gone in to better understand that, um, published in some of the AHA journals to help better tease that out. Um, we've looked at that. You do see with FCM, there's a transient reduction in phosphate, and then it comes back. And as part of our 3,000 patient trial, the FDA had us do an assessment of phosphate, and there was no evidence of any safety concern or clinical significance of any of that. So, trying to synthesize a message for our audience, I would say, uh, if available, I use the evidence-based formulations. If not available, we're often kind of stuck with what you have on formulary. And then it often comes up of when do I need to check iron indices again? And I'd say 3 to 6 months is reasonable based on the trial data we have.
Dr. Greene, Dr. Mentz, I need to interrupt you because we are at time, but I want to thank you both so much for your time and your expertise and, a really accessible webinar that I think can be a lot of learnings from. On behalf of the American Heart Association, thank you all for joining us today. And if you would like to learn more about Get With the Guidelines Heart Failure or any of our programs, you can click the QR code on the screen. Really appreciate it and have a fantastic day.